So, Alan, let me sort of put your prediction hat abilities on, lenses on. And, you know, we started this story with around KRAS. Well, maybe we started with EGFR receptors, where 90% of all colon cancer patients were candidates. We then got to 60% or so with KRAS testing. We're down to 40% or so now. Where are we going? Is it going to be 20%? What's the number going to be? Just so people get a sense of what percent patient's going to be just the right patient.
Well, it's an interesting question because we have to think about where we are today. And there's actually a very interesting paper that's coming out in the next few weeks. An abstract was presented a year ago by Tom Abrams at the Dana-Farber, who looked at the usage of the EGFR antibodies in a group where he had access to the usage rate for these chemotherapies. And it appears that somewhere only between 1/3 and 25% of patients who seem suitable for EGFR antibodies are receiving them. So perhaps the community is already ahead of us on this and has figured this out, but more likely we've got an educational problem or a gap. So I think my hope would be we'd be at 40%, which is probably the right percentage of patients, give or take, who should receive it of the total group. That would be my hope. We've got some questions we still have to answer, though. I think, remember, this all-RAS testing enriches for patients who have a chance of responding and probably aren't harmed. Within that subset, can't we do better than that? And that's what we have to get there. The question you asked, what do you do about the patient who's 3 weeks into their EGFR antibody? If they have a bad rash, I'd probably continue the treatment. If they don't have a rash at all, I might stop it. Again, the pharmacodynamics of the rash reflecting some biology. So I'm hoping we can get there with further information really to drill down. You could imagine doing a study where you take the expanded RAS population and do what the Everest trial did a few years ago, which is treat to rash, which sort of assures us of the exposure to adequate drug. So we're getting there. We're closing in, I think, looking at amphiregulin, looking at other factors also, such as male versus female, right-sided versus left-sided. I think we are kidding ourselves if we think we're done with this, but hopefully we'll zone in on really who benefits and not give it to people who don't benefit.
Very high-level practical question. I'll bet some of you guys are doing this testing in your own centers, and some of us are sending out. So I'm a send-out. We're sending out. You're probably running it in-house? No?
Well, we have a spin-off on the campus.
Yeah, okay. Yeah. So you own the business.
No, I don't.
You all are doing it in-house?
Doing it in-house.
We're running in-house.
You sending out or are you doing it in-house?
We're sending out.
We're sending out.
Commercial labs available.
Yeah, and so what we did for the send-out, and the folks who are out there who may be sending out, is we met with our pathology group, because they're the ones who are really doing the ordering on this, and reviewed the literature and said, okay, we want this expanded RAS testing. And it really wasn't that hard. It just required that meeting and clarification, because right now the reflex is just 12 and 13. Is that more or less what happened at your place?
Exactly.
Okay. And any other advice for you guys who are...
The practical issue, of course, is will insurers cover the expanded testing? And you need to be careful about that. I believe it will be in the NCCN guidelines, the newer version, although still it doesn't mean that insurers will necessarily cover it. The other issue, of course, is knowing how to interpret the results. And so you need to find a way to do the testing and then make sure you understand what the results will mean.